Thank you, Dentistry Academy, for inviting me to be a guest lecturer today. And thanks, Jake, for the lovely introduction. Okay, I think some of that was a little bit embellished. I'll have a short introduction of myself as well. And thanks, Jazz, for joining us this morning. And we're really blessed with an incredible line of speakers, both this week and in the past and next week as well. I had a few of my colleagues who had already given us their wonderful presentations, Doctors Jason Adinada and Dr. Steve Chang, both from Ontario. I miss you guys. Haven't seen you guys in quite some time, but hope that we can see each other in person sooner rather than later. Okay. So we're gathered here today at an unprecedented time. But what I want everyone to understand is that even though these are some difficult and questionable times for all of us, including dentists, I think we have one of the strongest health professions in the world. There's no other profession that is as strong and united as dentistry, and continuing education has always been the core of dentistry. Okay. I practice in Kamloops, British Columbia. In BC, we were given the green light to resume our practices as of this past week. We were given our guiding principles as of last Friday. And then, of course, everyone was in a mad rush to try to open this week. So it's a bit of a partial opening. Every province will certainly have different kinds of guidances and guidelines. I know that Saskatchewan opened before anyone else. Alberta and Manitoba joined shortly after, and British Columbia this week. I think a lot of us were starting to think, when are we ever going to practice dentistry again? Whether that's general dentistry, implantology, periodontology, oral surgery, we're all in the same boat. Whether you're a general dentist, a specialist, or someone who has a referral-based practice, it really doesn't matter. We're all dentists in the end, and we have to stick together and help each other, and that's why we're all here. Okay. So today's topic is, what is an immediate locator solution? Okay. I think we all come from a different and variety of backgrounds and training as well. So some of you probably already place implants and maybe place them on a weekly basis or even on a daily basis. And others are just starting to get started, and some of us are starting to potentially think about getting some training as well. So I will need to cover some of the basics, some of the background and foundations of implantology. Certainly that is in more respect to full arch therapy. And some of it will seem like maybe a little bit of review for you, but bear with me. I will share some pearls with you. This is what I do more or less every day, and it's I'm here to tell you that I'm nobody special, but I want to share with you what I've learned over the past 10 years. Okay? And so this is more or less where I started my journey in implant dentistry in 2010. I was a brand new graduate, very, very ambitious and motivated, like some of the students who are graduating now who have joined us today. And so let me tell you how I started, which is in dental school, I extracted 3 teeth for my past mother-in-law. Okay. And, if I can give you some advice, try not to work on your family, and certainly don't work on your mother-in-law. But I made a promise to her and my former wife that I would be replacing those teeth with implants for her. And so I took the proper training, a mentorship course in Vancouver. And And believe it or not, my first patient that I placed implants on after training was also my mother-in-law. Okay. Now, ironically, all three of her implants are doing spectacularly well, at least the last time I saw her. But you know, I started out as a general dentist, and I still am a general dentist, and I always will be. Like Jake said, you know, I'm proud to be in this dental profession, and it is a learning journey. Even though, you know, 10 years is actually what I consider not a very long time placing implants and doing dentistry. And every day I come into work, and most days I learn something new. And I hope that in another 10 years, when I've been practicing for 20 years, I hope that I continue to learn every single day, because, you know, it's without trying something new, okay, and learning from both your successes and perhaps failures, or maybe we'll call them mistakes, because the only failure is a mistake that we don't learn from. And so I started placing implants in 2010, and it became I I already had a fairly big passion in oral surgery, and I realized that, you know what, implants make a profound impact on patients' lives, and it also happened to be a discipline that I really enjoy doing. Like many of you, I am what you call a continuing education junkie, and used to travel. I used to take probably close to about 200 hours of continuing education a year, when really our only requirements are about 30 hours per year. And I took courses in not just implantology, general dentistry, endodontics, um, doing restorations, periodontology, you name it. I mean, there's so much to learn in general dentistry. And I think one of the toughest jobs that we have is being a general dentist. You have to be try to be good at most things that you do. Okay. And then, you know, if it's a discipline that you're either not good at, or you don't have maybe the interest in, then that's when you pass it on to a referring colleague, who may be better at doing things. So this was in 2016, Pacific Dental Conference. It is I believe, the largest dental conference in Canada, and maybe some of you were there. And a lot of people ask me, how did I end up being in this position? And some of my friends and colleagues come up to me, and I feel that maybe they're envious of my position. But to be very honest with you, I I I would say this is not necessarily the journey that everyone wants to take. I'm a general dentist, but I have a referral-based practice. I've had a lot of sleepless nights. I started this practice, my own practice, in 2015, so about 5 years ago now. And it's not always been that easy. Okay. And if I can give you an analogy, okay, I'm now 37 years old. I have two children, they're 10 and 8, two wonderful boys. I got married when I was 23, so a 23-year-old, and the reason being was I was in love and I didn't know any better. Okay, and it's the same thing with dentistry too. I wanted to start my referral-based practice, and to be honest with you, I didn't know any better, because you don't know what you don't know at the time. So I've learned a lot over the last 5 years, both clinically and professionally and personally. And I want to share with you today what I've learned over the last 5 years, some of the hardships and some of the success stories as well. So this was my debut on big stage, Pacific Dental Conference 2016. And we did a lower clearance, alveoplasty, as in bone reduction, immediate implants, 4 of them, 2 posterior to the mental foramen and 2 anterior. And the overdenture, the denture, which was fabricated ahead of time, that was loaded immediately, okay, as in on that same day. Okay, and we'll go over some of the protocols that I use for immediate overdenture therapy. I realize that this is a relatively short session. Typically, this is a 2-day course with often live hands-on surgery and demonstration, and also dry hands-on model practiced by doctors as well. Okay. And then also in 2019, so last year, Pacific Dental Conference, I had the privilege of doing another live surgery as well. And this was a different kind of surgery. This was an implant complication lecture, including periimplantitis, prosthetic problems, how to resolve a prosthetic screw that had been stripped, actually live on stage. I had to remove a final crown. I had to remove an ailing implant, and then placed an immediate implant, performed GBR, and then managed to create a chairside temporary crown as well. So overdenture therapy is a fairly large part of my practice. Immediate implant therapy overall takes up about 60 to 70% of my practice as well. And then the rest of it is oral surgery, which is typically surgical extractions, including impacted third molars. So we're all here today to get an introduction of what immediate overdenture therapy can do for not only our practice, but for our patients as well. So there might be a little bit of a lag on the audio, so I'll do more of a play-by-play here. Okay, 4 implants were placed. They were, if whenever possible, I try to place them with as much anterior-posterior spread. Okay. Yeah. And this is an immediate denture that was fabricated by one of my denturist colleagues, and it was picked up in the mouth right immediately after surgery. And the patient was able to go home with teeth that are more or less stable in the mouth. This provides not only an immediate solution, but also something that's very, very practical and relatively easier to implement in our offices. This is one of my heroes. We all know Tiger Woods, and just like Michael Jordan, I'm sure many of you have seen The Last Dance. This guy doesn't need any introduction. He probably doesn't need a biography either, because he's on TV a lot. But he's one of his biggest quotes is, "You can always become better." Okay, for those of you who are not golf fans, I actually don't golf anymore either, even though I'm a dentist. Is that a lot of things that people don't know about Tiger Woods is how hard he had to work to become at the top of his game. Okay, he had multiple back surgeries, and as a professional golfer, he changed his golf swing 4 times. Okay, that's unheard of in the golf profession. And I think of that in similar aspect to dentistry as well. Because someone who's at the top of the game and doing really, really well, why would you want to change something up? Okay, immediate overdenture therapy is somewhat similar to that as well. A lot of colleagues that I speak to, they will, the typical response I get is, why would you load an overdenture immediately? Isn't that dangerous? Isn't that putting undue risk to the overall treatment? So let's go over a few things about overdentures. Okay, but before we do that, let's talk quickly about what is an immediate implant. Okay, I know that the previous speakers have covered these topics probably a bit more in depth, but let me cover it for you quite quickly. There's immediate, early, and delayed placement. Immediate placement essentially means within the first 24 hours. early placement usually means within the 6 to 8 week period. That's usually the ITI, the Strawman group method. And then the delayed placement is really any time after about 4 months, once bone has healed from the socket itself. And then there's also immediate versus early versus delayed loading. Okay. Immediate loading is typically within the first 24 hours. Same thing with early, 6 to 8 week period. And delayed loading is usually after 4 months after the implant has what we call osseointegration. We also have what's called non-functional and functional loading. So when I'm placing an implant immediately in the anterior zone, say tooth 1-1 or 2-1, and we are putting in a temporary crown, that is what I would consider non-functional loading. Okay, and the reason being is the patient isn't told, advised, and also the temporary crown is made out of occlusion, so that it is unlikely that there's going to be undue force on the prosthesis, the internal prosthesis, as well as the fixture, as in the implant itself. Whereas functional loading would be either a full arch prosthesis, okay, or potentially maybe anything that's splinted. Maybe we've placed several implants and placed in a temporary bridge. Now, why immediate? Okay, because there's a misperception and perhaps a misunderstanding of immediate in respect to satisfaction for not only the patient but the clinician, but also for the overall success. Okay, because yes, we want to do things as quickly as possible. Okay, especially in times like these during COVID-19, when we are supposed to be as efficient as possible. Obviously, we have reduced amounts of PPP available. We don't want patients to coming in as for as many frequent as appointments as well. But we want to make sure that whatever we do for our patient, it increases our success level. Okay, and this is in the background here. Let's see if I can show you here. Okay, these two implants here. Okay. These were actually not placed by me, but one of my colleagues. He's I won't put his name, but he has given me permission to show some of his photos in the past. And you know, the reason that I show this case is not to give an example of what not to do, because I've seen this particular case, as well as others that are somewhat similar, performed actually at a really great level. When I saw the case from start to finish, I thought, you know what, I couldn't have done it really better myself. But these 4 implants, they were placed immediately, but also they were covered, as in you have primary coverage by soft tissue, and they were not loaded. So for those of you who already do some overdenture therapy or are familiar with the protocol, most of you, if not all of you, are probably not immediately loading your overdenture. Okay, most of you are probably placing cover screws, getting primary closure, and then possibly having maybe the patient not even wear a denture for maybe a month to even 2 months. Okay, this particular patient had primary coverage, implants placed what I consider at a really ideal level. Okay, there was plenty of bone. It should have been a very, very successful case. But when the second stage surgery, as in a flap was done and reflected, and the implants were uncovered so that second stage could be completed, unfortunately, there was actually quite a bit of substantial bone loss around all 4 fixtures, and one actually had to be removed as well. And one of the reasons was because of soft tissue trauma. When a denture is placed, whether there's primary closure or immediate loading, if the denture keeps moving around, then that can lead to soft tissue trauma. And soft tissue trauma will often lead to also trauma to the bone underneath, which can lead to bone loss. Okay. So let's quickly cover the treatment options for edentulism. Okay. We have on the left-hand side, removable prosthesis, removable options. We have the fixed options. I'm not going to talk we won't discuss much about fixed options. I think some of our colleagues already have. And we are going to focus everything on the 4-implant overdenture option. Okay. In the past, and actually in the more recent past, 2 locator abutments or ball overdentures was what was considered the standard of care. Some of my colleagues are still using ball abutments. Those are being more or less phased out. There's many different attachment systems, and but for the most part, the general public, the dental professionals, including denturists and both dentists, okay, all are coming to the consensus that especially for the mandible, where the success of a conventional lower denture is relatively low, we need some sort of other ways of having extra retention for the denture. Okay. Now there's other options such as bar overdentures. I used to do actually quite a lot of these in my city. In fact, actually a lot of patients would be coming in to have their bars fabricated. But there's extraneous costs associated with bar overdenture therapy. It is much more difficult to keep them clean. Okay, passivity can be an issue. Okay, the reason being is that, in my opinion, a bar overdenture should be at an abutment level rather than at the fixture level. Okay, you do require a lot more room, as in space, for the prosthesis. Okay, and taking an impression, if you were to do it at the fixture level, is often a lot more difficult as well. Okay. So a lot of cases I've actually converted to overdentures with locator abutments from both the bar, and sometimes I'll even actually convert patients from fixed to removable, but this is all case dependent. It is more difficult to keep a bar overdenture hygienic. Often the tissue is edematous. When the patient comes into the office to have the hygiene appointment, what I would do is remove the bar itself, okay, and clean that bar extraorally, and then do the hygiene for the rest of the mouth without the bar present. And one of the reasons I just love doing overdenture therapy with locator attachments is that it is super simple and easy for patients to maintain. So here we have a patient. She's had 4 implants placed, immediately loaded. And she's come back for her 2 or 4 month post-operative appointment. And it is dead simple, literally, to maintain these for patients. It is certainly not without problems, and I'll cover a couple of those today as well. And I will certainly not admit that it's by no means a perfect therapy or perfect option for every single patient. Okay, there definitely is no cookie cutter method for all of our patients, and whether we choose the removable option or fixed option, a lot of this depends on not just finances, but patient preference, patient's medical and dental history, how able they are in maintaining the prosthesis and their implants, how reliable they are in coming into our offices for maintenance, but also clinicians' level of knowledge, clinical skills, and also preference as well. And then here's what we know on is the all-on-X therapy, okay? Previously known as all-on-4 therapy. I call them all on X because some patients get 4 implants, some patients get 5 or 6. I've even had as many as 8 implants for a fixed arch. And this was certainly what was considered revolutionary when it became more common knowledge, approximately about 10 years ago. It's a fixed bridge with multi-unit abutments. And the whole premise is that everything is splinted together. Okay, and typically there's a superstructure, a substructure, typically a wraparound bar. Okay, it first began as a hybrid prosthesis. Hybrid means that there's a bar on the inside. Okay, and then hybrid because denture teeth, acrylic teeth, are bonded to the bar itself. And certainly this changes lives for a lot of patients, and it can bring a ton of benefits, but just like any therapy involved, there's also pros and cons. And the whole premise behind all-on-X therapy was to avoid overloading, okay? And the reason that this therapy could be done immediately, as in on the same day, and the patients are given teeth in the beginning, even to even function and almost go back to a semi-regular diet, is that all the implants were splinted together, okay, and nothing was coming in and out. Implants are very good, are poor with tension, okay, but typically actually fairly good with compression in the beginning. And so all-on-X therapy or fixed arch therapy, okay, that is the reason why there is a high success rate for the implant to osseointegrate. And this kind of therapy is also done at my office. For me, it's done more selectively, and it has a lot to do with patient's demand, patient's history, okay, and also their preference as well. Okay, and so here's an example of an all-on-6 therapy with it's a pectin bridge with it's a pectin substructure. There's actually no bar on this one, and then Emax veneers. And this patient has been in had this done about I think almost 5 years ago now. Okay. And oh, this is an older photo. But it's going on almost 5 years now, and you can see that there is an ample amount of keratinized tissue. Okay, all the implants are doing well. Bone has been maintained, and patient is very, very satisfied with the therapy that has been provided. Patient also comes in every 6 months, is a younger patient, and really wanted fixed teeth rather than removable. Okay. There's another patient here. Okay, she had 2, 4, 6, 8 implants. Okay, there's a reason behind and a story behind why she had 8 implants in total. Had a lot to do with her anatomy and why 8 was required rather than 6 or 4. But imagine taking this type of impression. Okay, it has to be all splinted. Most of these were abutment level impressions. Okay. And as you can imagine, taking an impression for a full arch case, whether it's for 4 implants, 6 implants, or more than 6 implants, it becomes exponentially more difficult because there is literally no room for error, no margin of error. Okay. So today's topic is the removal option, and it's the locator overdenture option. The overdenture can be removed both by the patient and ourselves. Doesn't require a lot of special tools. Patient is able to maintain hygiene on their own without using a water pick, whereas a fixed prosthesis, hygiene can be more of an issue. Okay. And here is a patient. Let's just to show you how retentive an overdenture can be. So this patient had the implants on actually 2 weeks prior. And you'll see that the implants have what we consider AP spread. Okay. Soft tissue, you can see that has healed relatively well just for 2 weeks. Okay. And what's really, really critical here is that the overdenture engages all 4 implants passively, okay, but also simultaneously as well. So types of locator treatment plans. We have, I briefly mentioned about 2-stage, means that the implants are placed, maybe the ridge has already healed, okay, or maybe the extractions are done and simultaneous implant placement. But primary coverage with soft tissue. Okay. 1-stage, which means that implants are placed, but delay loading. So you could have healing abutments, or some people call them healing caps. And the denture could have maybe a soft reliner or a tissue conditioner. It could also be loaded early, as in after about 6 to 8 weeks, or immediate loading. When I first began doing overdenture therapy, I started with stage 2, and then I brought it down to 1-stage, delayed loading with healing abutments, and I found that we didn't have actually any issues with delayed loading. And then as the technology with implants and surface have improved, I felt confident that we could load implants at around the 6 to 8 week period when the ISQ level was acceptable, as in typically for me is beyond 70. It could be as low as 65, but the higher the better. Dr. Jazz mentioned in his presentation why he uses ISQ therapy. It is a great quantitative indicator of implant osseointegration. Okay, and then so I would say about 90% of my patients are now having immediate loading. Okay, so certainly by no means do all patients have same-day loading of their implants. But what are the advantages of immediate loading? Obviously, the patients have more satisfaction. Nobody wants to go without teeth. A lot of patients who get delayed loading are advised not to wear their denture for potentially 2 weeks, 4 weeks, even as long as 2 months. And that has a lot to do with the implants possibly getting overloaded, but also with soft tissue trauma. In my opinion, soft tissue trauma is just as critical as implants not being overloaded. Okay. Now, with obviously immediate loading, we're looking at potentially just 1 surgery rather than 2 or 3. From my experience, we have usually better soft tissue healing, usually fewer adjustments, and the reason being is that the denture is retained by the abutments, meaning that there's minimal movement. So if we have minimal movement, then there should be also less trauma to the soft tissue, also meaning that fewer sore spots as well. Okay, and this is more of my personal opinion, but maybe there is actually even faster, better osseointegration. I don't have any science behind that, but maybe this is more like progressive loading. Okay, and certainly this should not be the primary indicator for immediate loading, but patients usually do have a higher acceptance rate as well. It is a paradigm shift. Okay? And when I present this procedure or protocol or principles, sometimes I get people who share resistance. Okay, but it is actually, in my opinion, not a brand new. It's not a new therapy that I've introduced. Okay, I've just tweaked it over the last 8 years that I've been doing immediate loading. So many of you are familiar with the term or have done mini implants. And for those of you who do mini implants, and hopefully successfully in your practice, often they're done flaplessly. And so mini implants sometimes have a bad reputation in implantology. They can certainly work I think, successfully in a lot of clinics, in a lot of people's hands. I personally don't do them myself, But what I wanted to explain to you is that mini implants, even though they're very narrow diameter implants, they are traditionally or normally loaded immediately. Okay, what I'm doing is using traditional regular size implants. So the narrowest diameter implants that I use in my office is 3.5. And so these are traditional implants that we would use for anterior cases or premolars. I go even as wide as 4.5 or 5 millimeter diameter implants, but these are regular implants that are meant to be more or less permanent. Excuse me for a minute. It's a good thing I'm not coughing in front of patients, right? Hopefully some of you are laughing. Excuse me. So let me cover for you just very, very quickly what the research is behind immediate loading on locator abutments, because this is not something that I've made up for you. Okay, in 2010, in the International Journal of Oral Maxillofacial Implants, very, very small sample size, 8 edentulous patients, but 100% success rate after just 1 year. Journal of Periodontology, 2012, bigger sample size, 96 implants in 24 patients. These were ball attachments, and a similar success rate after 1 year, 98%. Another study, 20 patients, this time tooth Straumann implants per each, ball abutments, 100% success after 2 years. And the authors concluded that the survival rate and the overall health-related quality of life was similar to that of patients getting standard treatment. Or how about a thesis? This was the immediate versus delayed loading of 2 implants. And what was significant in this paper is that marginal bone level changes around immediately loaded implants are comparable to those seen around implants loaded 6 months post-surgery. And a meta-analysis, which obviously has a higher power in research. And immediate loading of mandibular overdentures, survival rate was 96 to 100%, depending on the article itself. And this meta-analysis included 4 Straumann studies and 3 Nobel studies. Okay. So some of you may have noticed here that some of them are smaller sample sizes, but all of these studies, and there are more out there, okay, the duration that patients were followed up is relatively short, okay? And without boring you with research, we're looking at about 1 or 2 years. And some people ask me, well, it's not a 10-year research, okay? And I had some people who maybe some reps that didn't quite believe in what I was doing because I don't place their implants. In implantology and dentistry, there can be a lot of competition. I think we should all support each other. But when people feel threatened, they start asking questions, and they should. Okay, so I got asked this question, which is, these papers are really, really short term. You really need a 10-year research before you can start actually teaching this concept and doing this therapy on a regular basis. So how can unsplinted implants be functionally loaded? Okay, because a removable prosthesis is considered unsplinted. But really, are they unsplinted? If you look at this Panorex here, okay, you have the fixtures, so you have the abutments on top, and you'll notice acrylic, okay, which was used to pick up the overdenture in the mouth on the day of the surgery. Okay, so while it is functioning in the mouth, everything is actually somewhat splinted. And maybe this has to do with progressive loading. Okay. We need two special products. Okay, and something else I want to cover is, then somebody asked me, because it's a short-term research, okay, say 1 year, okay. Let's say I placed an implant on the day of the surgery and loaded immediately. Somebody loaded the same implants, but only 4 months later, okay? And 1 year later, we have more or less the similar marginal bone levels. Does it really matter whether it's been now 1 year, okay, or 10 years or 20 years? If after 1 year, the implants are healthy, soft tissue is healthy, bone levels are adequate, I don't think it really makes a difference whether it's been a year or 10 years, if we're talking about the same type of therapy as in an overdenture, okay? Because we're not comparing overdenture versus fixed. So 2 special products, implants, attachment system. Let's quickly talk about the locator abutments for those of you who have not used this in your practice, okay? And they come in a variety of heights, and that is what makes this type of therapy more versatile as well, okay? And these heights will correspond to the soft tissue level. The male attachments, okay, those go in the denture itself, okay, and so think of those as the caps, and these caps come in a variety of resistances. Think of them as tension, and it also comes in, depending on which system you use, the most widely system that is used still is the Zest locator system. Okay, but there are some other systems available and comparable as well. But some of these are, they have the non-extended range, as in if the implants are more parallel, then we can use the caps on the left-hand side. If the implants are a bit more divergent, then we need to use the caps more on the right-hand side. Okay, but let's skip the slide here. Okay, so let's talk about what we do on the day of the surgery, okay? What actually happens. So sequence 1, well, first of all, we have to give local anesthetic. And in my practice, we do mostly IV sedation, but we obviously make the patient comfortable, local anesthetic. Dr. Jazz talked about how to implement implantology in your practice, and including that is the setup and training your staff. Okay, extractions. Okay. And what I do, and this is a critical step, is I take a bite registration, okay, of the patient, okay, before I proceed with any other further surgery. Just like fixed arch therapy, and in fact, just like single tooth therapy, we want to make sure that we maintain the correct bite for the patient. Okay? And this is critical in having success for your implant, or implants actually. And the reason being is if the patient has an improper bite, then that could have ill consequences for the implants themselves. Okay? Extractions, and then ridge reduction, otherwise known as alveoloplasty. Okay, now so this is a concept that is opposite to what we've been taught and what we're used to and what we preach as dentists. We want to preserve as much bone as possible, right? We've had speakers talk about socket preservation, which is actually ridge preservation, okay, alveolar ridge preservation, so that we don't have bone loss and we can place implants at a later date, okay? But for overdenture therapy, we actually need more space. We need space for the prosthesis, we need space for the attachment, and we also need space for the implants, okay? And not just vertical space, but we also need horizontal space as well. So if you look at this ridge, I've actually flattened it down, and the reason being is that I don't necessarily go all the way down to the basal bone level, okay, but we do need sufficient space for all our components, and also we need space for the implants themselves horizontally. Okay? If this hasn't covered me before, a general rule of thumb is that you need 2 millimeters of buccal bone and 2 millimeters of lingual bone, and more the better in general. Okay, extractions and ridge reduction, I plan this out before I even see the patient. Okay, and obviously we use a traditional radiographs, but also cone beam CT. And also what should not be underestimated is actually looking at the model. Okay, traditional dentistry, taking impressions or digital impressions and having the models mounted. Okay, and even though I primarily just do surgery, I want to look at the restorative aspect as well with whoever is restoring this patient. Okay, I work primarily with denturists, but also dentists as well, and we plan each case to determine what is the ideal amount of bone reduction. Okay, and this will also depend on whether the teeth have super erupted. Okay? And so the bone reduction is completed. Okay? And let's just quickly watch a video of bone reduction here. Okay? This is actually one of my older videos. So this one's a little bit outdated, I apologize. But what's really, really important here is that the floor of the mouth is completely protected. Okay, so I protect it usually with a Minnesota retractor. Okay, but also what I do is I do a suture to tie back and prevent the accidental iatrogenic trauma to the patient. Okay. We'll go over quickly about the anatomy that's involved with this therapy as well. Okay. This can be one of the most underestimated and difficult part of overdenture therapy. Okay. So implants are placed immediately, sometimes in the socket, and sometimes away from where the teeth were. Bone grafting often needs to be completed as well. Okay. I do personally utilize PRF and sticky bone in my practice, which I think has been covered with other lectures as well. Okay. So let's talk about the anatomical structures that are involved. Okay. And these are extremely important. Okay. So lingual artery, okay, that's part of the floor of the mouth. Okay. You hit that and that will become a medical emergency. Okay. So I could talk about this for probably the next hour, but mental foramen and the anterior loop. And we want to stay away from the mental foramen for obvious reasons. And the reason being is that we don't want to give a patient a numb lip. Okay, the sublingual or the submandibular fossa. Okay, and obviously the inferior alveolar nerve. Okay? And so we want to make sure, absolutely sure, that whichever posterior implant we're placing, okay, is anterior to not only the mental foramen, but also the anterior loop. The anterior loop actually, so the inferior alveolar nerve comes down, okay, and actually goes a little bit anterior, and then comes back posterior. And typically you can see that on the Panorex. Okay? And depending on what article you read, you want your most distal part of your implant to be 3 to 5 millimeters anterior, okay, to the anterior loop. And another critical part of overdenture therapy, especially if we're doing immediate loading, is the suturing aspect. Okay, because we're not getting primary, what we are in essence getting primary closure, but what I am getting is primary closure around locator abutments. Okay, so we want to make sure that we minimize what's called dead space. Okay, and this principle you can apply to really other aspects of implantology as well. If you're doing guided bone regeneration, okay, if you're doing soft tissue grafting around your implant, you want to minimize dead space. What is dead space? Okay, it's the space between the soft tissue and the bone, essentially. Okay. So what are the requirements for immediate locator overdenture solution? Okay. One, obviously, is primary stability. Okay. Now, primary stability is different from primary torque level, okay, versus actual initial stability itself. I can get an implant to torque to well over 35 or 45 Newton centimeters, but that implant may not be stable enough for same-day loading. So what I usually like is a good rule of thumb is that at least half the implant is a native bone, okay? As in, I'm not grafting more than half that implant, okay? And the reason being is that that grafted bone is going to become native bone, okay, over a period of months. And I want to make sure that while the osseointegration is going up, okay, and primary stability is actually going down, okay, that we don't jeopardize our implants. Implants with high bone to implant contact surface, we talked about good suturing and good isolation, okay. We do need adequate clearance, a well-fitting denture with proper bite, and of course, a patient who's compliant as well. Okay. A tip that I'm going to share with you is that these patients are put on a very, very soft diet for 2 months, typically. Okay. I'm just checking my time because I'm actually at work and I have a patient coming in. But I think we'll still have enough time for a little bit of question and answer period. Okay. So our mandibular overdentures, whether we're doing immediate loading or delayed loading, okay, because what I'm telling you is that you don't necessarily want to do what I'm doing in my office, okay? It all depends on your experience level, your knowledge level, and also your comfort as well. Some of my doctors who have taken my previous courses, they are still not doing same-day loading. Not all of them are, okay? But what I've given them is a foundation for overdenture therapy, which can be applied to both delayed and immediate loading. So are mandibular implants foolproof? They certainly are not. Okay, these are not my implants. Okay, but what I'm going to tell you is that they could be my implants. In fact, some of my implants have looked like this. Okay, nobody has a 100% batting average. Okay, but fortunately in dentistry and implantology, we do have a fairly high success rate. Okay, this is I've heard others, and I used to think this way as well, that overdenture therapy, implants placed on the mandible, is probably often considered the easiest type of implants to place, especially for a beginner, okay, or intermediate implant placers, okay. But the more and the more I do, the more I find that the less I know, okay. And it's certainly not a foolproof method. There's a lot involved in not just immediate success, but long-term success as well. Okay. So right now in dentistry, we're just getting back into work. I know in Ontario, you guys are still shut down. I really, really hope that you guys will be able to open up soon and see those patients who have been waiting patiently for dentists to be able to work again. So typically this this procedure is taught over 2 days, and actually the last one I taught was in Toronto. For those of you who are joining from Ontario, but typically, you know, there's usually about a 1-day lecture. We have a hands-on component, and depending on where it is. Where the course is held, sometimes I'll be able to do a live surgery as well. If I'm doing a course in Kamloops, British Columbia, by the way, that's about 3.5 hour drive from Vancouver, 3.5 to 4. And it's usually a 30-minute flight. And when I hold the course in Kamloops, I'm able to do live surgery demonstration as well. And that way you can learn exactly what I do from step A to Z. So let's conclude our presentation with one of my patients. Now I've talked about the what of overdenture therapy, okay? How to do overdenture therapy, you know, when is it indicated? and what are the things that we have to consider. But something that is even more important is why we do what we do. Okay, and this is one of my patients. She made a profound difference to me, to my practice, and I just want to share with you what her story is. So this is Zakia, and she was referred to my office. She traveled about 2.5 hours away, and she's had a lot of dental work done over the years. A middle-aged woman, and in her 50s. Um, she hasn't smiled in well over a couple decades. Okay, and she is actually she actually has a beautiful, beautiful smile, but nobody ever sees it. And you'll notice that she's got actually a lot of lipstick on, and you can see that even on her teeth. Okay, because she doesn't smile, and so she makes up for that with more makeup. She's got obviously an overclosed dentition. Okay, she's had a fair bit of restorations over the years. Okay, she's lacking posterior support. She's unable to chew, unable to smile, and certainly not enjoying her life to the best of her abilities. And she's got many, many years that she could enjoy as both a mother and a grandmother. Okay. And let's look at the lower dentition. Okay, certainly not terminal dentition, but she wanted not just a better smile, but more functional teeth as well. So what we completed for her was immediate loading on 4 implants for a lower overdenture. And this was a 2-week photo for her. And, this photo it has more impact on us as dentists, but not for her. But she was so happy and grateful. Not only did she have a minimal amount of discomfort, but she was able to smile again. Okay. And this really gave back her life. And, in dentistry, we have some tough days. I think non-dentists don't understand how difficult our profession can be. And, we have to have reward outside of just finances, okay, and being able to provide a good livelihood. And the profound impacts that have in my practice and my life and my career are the patients who come in and they tell me that this was the best decision they've ever made. And she comes and sees me every year for her annual implant exam. I do not ask all my patients to kiss me or even her, but she always wants a photo taken with me. And she tells me that she's able to chew better, smile more, and she even feels younger as well. Okay? So this is about as much as I can cover in a short period. For those of you who are on Instagram, I invite you to follow me. My handle is implant_HY style, okay? Because HY stands for Ho Young, okay? And I have many cases on there, both overdentures, immediate anterior implants with temporization, posterior implants, sinus lifts, GBR. I have some lecturing photos as well, and some of my hobbies. If you want to see a video of me cliff diving, is that cliff diving? No, actually, that's bungee jumping, cliff jumping. Okay, but a lot of these are clinical photos. Please follow me on Instagram, and you'll be able to see more cases. I'll certainly upload more this year. And for those of you who have more questions, maybe some interest in future courses when we can all travel for both work and personally as well, email me personally at cejacademy@gmail.com. Okay. My goal is to have you come and join us and have not only great education, but I want everyone to have a connection, an experience, and a journey. I shared with you that I used to travel a lot for as a student, and I still used to travel a lot as a teacher as well. And what I find is that dentistry is it is a very, very, not just challenging profession, but it's really, really taxing on us both physically and mentally. Okay. And what I've learned by taking courses and by also sharing and educating other dentists is that something that is missing in dentistry, okay, is the journey and the experience and the connection. And we go to these far places, whether it's British Columbia, if you're from Ontario, maybe Florida, or even to Europe. And we typically arrive the day before the course, late at night. Okay, you go to the course the next day, usually with jet lag, and you finish your course, and then you run back home because your family's waiting for you, and the next day you have to work. Okay, and I found over the years that the best courses are the ones where we can meet new friends, make new connections, have an experience that's not just dentistry. My next course that I'll be doing is a private mentorship for overdentures. For those of you who have already taken module 1 for immediate overdentures, and it'll be held in Kamloops, probably more with local dentists around BC. But I want people to come and take something back and be able to take it back to your office and not just implement it on the next day or the next week, but have a more fulfilling career and life. Okay? Thank you very much. It was my pleasure. And I do want to introduce our next speaker, which is tomorrow. Okay, this is my best friend, Dr. Neki Jamal. Okay, he's from Lloydminster, Alberta. I think he's been mentioned before as well. And I feel like I'm the Hisham. I feel like I'm the opening act. Okay, and he's going to be finishing off the week. He is by far the coolest, the most generous, okay, and certainly the best dressed dentist educator that we have in Canada. Okay, you guys are going to have a great day tomorrow with Neki. He's got some phenomenal slides and phenomenal tips. Okay, and I guarantee you will learn something about exodontia, local anesthetics, how to become a better dentist. This guy, he goes to far places and drills wells we're talking. Anyways, I think that's enough introduction for Neki. Thank you all for joining me today, and I can stay behind for about 5-10 minutes for question and answer period.
Awesome. Thank you so much for that, Ho Young. We really do appreciate it. That was very informative. We're going to go ahead and skip the housekeeping announcement. We'll do that afterwards. I'm going to go ahead and pass the mic right on to Dr. Jay Carrier to ask you some questions.
Ho Young, thanks so much, man, for that. Amazing as always. You never disappoint. Have a few questions here. So the first one is, with advancing popularity of implantology, there's a higher demand in doing atraumatic extractions. Do you see any benefit of using hard tissue lasers for this?
Certainly for immediate implants in both the aesthetic and the posterior zone, when we are preserving both the soft and the hard tissue, certainly there's different methods of achieving atraumatic extraction, whether it's by piezo, using instruments like the Proximator from Carl Schumacher. By the way, I use that kit for almost all my extractions for single and multiple implants. I do have a laser in my office, but I don't usually use it for the extraction itself, but I have seen that in other presentations, using a hard tissue laser to essentially sever the periodontal ligament. So certainly there's different methods available. My recommendation is use what works for you. Okay, I don't always use a Proximator. I don't always use a piezo. What works for me may not work for you, and vice versa. Now, as far as the question was for overdenture therapy, it is, by definition, it's actually a traumatic extraction. I mean, every extraction is traumatic, right? But no, it is not minimally traumatic for overdenture therapy. And the reason being is that almost all of my cases require bone reduction and a full flap. So I think the message I can give you is get those teeth out as soon as you can. Don't induce more trauma than you need to. So I'm not saying that just rip out the teeth, but we do need to perform ridge reduction, which probably does means that minimally traumatic extraction is probably not quite as applicable.
Gotcha. Perfect.
Yeah.
The next question is, what are your thoughts on immediate implant placements and immediate load in the maxilla with locators? Many respected circles advocate for a bar for the maxilla and locators for the mandible.
Yeah. That's a very, very good point. And whoever asked that question, thank you very much for bringing that up, because it is a very, very important point. I've heard some circles say that doing overdenture therapy on the maxilla is contraindicated. I disagree, but then again, we can agree to disagree. Personally, I do both fixed and removable for the maxilla. And that depends also on bone density that's available. And at the same time, and maybe others may not agree with me, I think some patients actually are not good candidates to have implants done, okay? Especially for the maxilla. I run across cases where the bone is, we're looking at not just like D4 bone, but a category of its own, like D5. And it's, you know, I hesitate on placing implants for some of those patients, even with, you know, sinus augmentation. So it is certainly, I make that decision case by case. Do I do overdenture therapy with locator attachments for the maxilla? I certainly do. Do I recommend that to the doctors who take my courses? Not necessarily. I recommend starting with the mandible, being selective with cases, because some mandibles you will run across where the bone is not just D3, but D4, okay, or even softer than, or more porous in D4. And there are some cases where even I hesitate on placing implants and loading them, especially on the mandible. So, you know, it's a case-by-case decision.
Perfect. Another question here. Do you have enough time, Dr. Chung?
Yeah, I'm okay right now.
Okay, good. So how do you choose locator height at the time of placement? And do you ever have to change heights once the tissue is healed?
Another great question. So it was initially more trial by error. This is a question that comes up at our workshops, at every single workshop actually, okay? And the reason being is, traditionally, when implants are placed, let's say we have primary coverage or even healing abutments, and we wait, let's say 2 to 4 months traditionally for osseointegration. That allows for not just the bone to remodel, but also the soft tissue, right? And then what we do is later on, we do either the uncovery or take off the healing abutment. We measure the soft tissue height. That's the traditional method. And then that's when we decide on the height of the locator abutment, okay? So what I do on the day of the surgery, and this is kind of a general recommendation, but I measure the tissue height, okay? I also take into account how deep the implant is placed as well, okay? And then I suture. I compress the tissue to reduce dead space, okay? And it is a bit of an estimate on what height I need for the locator abutment itself, okay? Will soft tissue and bone levels remodel slightly? Yes, they will, but because we've done the bone reduction already, okay? So will the bone remodel after that? Probably a little bit, but not significantly the way I do my procedures. So occasionally, yes, I do have to change the locator abutments. And I usually do that after about 2 months.
Okay, and just one more question here. So, so I was wondering what type or brand of locator abutments are we seeing in your photos?
Those are all Zest. Yeah. I do use the Novalock system from Abutment Direct. They have several different kinds. Zest produces locator abutments for almost all implant systems are available, certainly the ones that are available in Canada. They are implant specific, but the part that you see on the outside, the last approximately 1.5 to 1.75 millimeters, it's all the same. What's different is how they connect to the implant, okay? Because every abutment needs to be specific for that implant system and the size and platform.
All right. Well, that's the end of the questions, Dr. Chung. Thank you again so much for all you've done for us today, and good luck treating patient day. We can't wait till we do that.
Yeah, today's right when you say that, we're very jealous, Ho Young, that you're doing that. But thank you again for taking the time out of your, I'm sure, very busy day to help us out today.
Yeah. Today's my second day. It's a bit of a slower start in BC too. It's actually my first implant patient in just over 2 months. Yeah, and it's actually an overdenture therapy. It's like riding a bike, right, guys? Yeah,
exactly.
Don't fall off too much. Wear a helmet, okay, or a face shield. Yeah, yeah. Hopefully, you guys will all have adequate PPEs as well. And I know that's a concern for everybody all across the globe. I hope to see many of you soon in person. Okay, Hisham, whether that's in BC or in Ontario, Jake, Jazz, and for those of you who have joined us all across Canada, if you have further questions, please feel free to email me. Like I said, it's cejacademy@gmail.com, or you can also follow me on Instagram, implant_HY style. Thank you.
Awesome. Thank you so much for that, Ho Young. We really do appreciate it. And I know you got to run, so we'll be thanking you later on as well. But once again, you blew it out of the water, and it was a very informative session. So we do appreciate it.
Yeah, and thank you, Dentistry Academy, for putting all this together. You guys are great.
Thank you.
Yeah. Cheers.
Tomorrow, May 22nd at 12 p.m., we'll be wrapping up week 3 with Dr. Neki Jamal, who'll be talking to us about simplifying tricky third molar extractions. For those who are still with us, if you have not signed up for this course, I promise you it will not disappoint. There are only a few spots left, so please make sure that you tune in. And then following that on Monday, we'll be beginning week 4 with Miss Melissa Calloway, who will be talking to us about how to build your network to jumpstart your return to practice, followed by Dr. Mike Ling, who will be talking about doubling your case acceptance. And for those of you guys who do not know Mike Ling, he started a program or a talk called Practice on Fire in the United States, and that's absolutely taken off. He has owned and operated one of the biggest and most efficient practices that I think Canada has ever seen at one point. So please make sure that you tune in on Monday. Just as a quick reminder, tomorrow's session starts at 12 p.m. and not 11. We'd like to thank our co-hosts for the day, Dr. Azim Sheikh and Dr. Jake Carrier. Jake, we're looking forward to your talk next week. And we would like to thank our speakers for the day, Dr. Jazz Tekar and Dr. Ho Young Chung, for such incredible presentations. Jazz, you did an incredible job. Well done. And Ho Young, once again, thank you so much for a great presentation today. Have a great day, everybody. Enjoy the beautiful weather, and we look forward to seeing you all tomorrow at 12 p.m. Bye-bye.